Hello friends, welcome to the Case of the Week series by Gujarat State Chapter of IRIA. Myself Dr. SAMIR PATEL, Consultant Radiologist at UN Mehta Institute of Cardiology and Research Center and at Vikas Sonography Clinic, Ahmedabad. I am going to present the case number 3. A 28-year primee, no history of abortion or bleeding in present pregnancy. First ultrasound at 7 weeks for confirmation of pregnancy. No late first trimester ultrasound, so-called anti-scan or 20 weeks anomaly scan due to lockdown. No history of any intervention in present pregnancy. Now came for anomaly scan at 27 weeks gestation. So as routine, sonography started with BPD, HC, cranial structures, facial profile and orbits. All appears to be normal. But traversing through the abdomen of the fetus shows marked peritoneal fluid collection suggestive of fetal ascites. The stomach appears to be normal and bowel loops also appears to be normal. Then seen for the GUT, the kidneys and urinary bladder appears to be normal. 3 vessels umbilical cord with normal flow, and also there is normal flow in fetal middle cerebral artery, but there was reversal of A wave in the fetal ductus venosus. There was also minimal amount of pericardial effusion. So there is all pericardial effusion with fetal ascites. So at more than 2 species of fluid collection in the fetus suggests fetal hydrops. So we have to evaluate for fetal hydrops. We have to evaluate immune hydrops and non-immune. There is, according to history, no likeliness for immune hydrops. So we have to think of non-immune hydrops. In non-immune hydrops, the etiology may be cardiovascular causes like arrhythmia, myocardiopathy, obstructive lesions. Then genetic causes like trisomy 21, 18, 13, Turner syndrome, Noonan syndrome, skeletal dysplasia, myopathies, and metabolic disease. Congenital infections like cytomegalovirus, pyrovirus, rubella, varicella, herpes, toxoplasmosis, and syphilis. Some hematologic causes are like non-immune anemia, alpha thalassemia. Some placental causes like twin transfusion syndrome in case of monochorionic twins, and some miscellaneous causes including respiratory system, pulmonary sequestration, adenomatous malformation, tumor and chylothorax. Some genitourinary tract lesions like obstructive uropathy, thrombosis, nephrotic syndrome. Some gastrointestinal tract anomalies like duodenal or jejunal atresia, imperforation or peritonitis. Some tumors like sacrococcygeal teratoma, neuroblastoma, hepatoblastoma, or maybe idiopathic. So, in this case, there is no history favoring immunohydrops. Abnormal ductus venosus flow suggestive of reversal of A wave. No diffuse soft tissue edema. Normal flow in fetal MCA. Rule outs fetal anemia. Then normal GIT and GUT, and there is findings favors cardiac anomaly. So started detailed fetal heart evaluation. In 4-chamber view, there is dilated right atrium, then persistently open foramen oval flap in left atrium, then flickering movement of tricuspid valve with thick cusps, very small right ventricular cavity with thick wall, a compressed or small left atrial cavity, normal opening and closing of mitral valve, and normal LV function. On putting color, the left ventricle fills properly while right ventricle fills very minimal through the dysplastic narrow tricuspid valve. So now going to the outflow tracts. The left ventricular outflow tract and ascending aorta appears to be normal. but there is thick echogenic membrane in place of pulmonary valve with small hypoplastic confluent pulmonary arteries. So LVOT measures around 5.6 mm while pulmonary artery measures 2.4 mm suggests significant hypoplasia. So going upwards toward the 3 vessel trachea view, very small left-sided pulmonary artery seen in proportion to the or comparison with the aorta, and on putting a color there is reversal of flow in the ductus arteriosus, and also it is confirmed in the sagittal view. So my fetal echocardiography findings are dilated right atrium, persistent widely open foramen oval flap in left atrium, thick dysplastic tricuspid valve with severe stenosis, very small RV cavity with thick wall, intact ventricular septum, thick membrane in place of pulmonary valve, hypoplastic confluent pulmonary arteries, retrograde filling by ductus arteriosus. So diagnosis of pulmonary atresia with intact ventricular septum. So in pulmonary atresia with intact ventricular septum, there is usually small RV cavity with thick wall of right ventricle, or there may be dilated right ventricle with significant tricuspid regurgitation. Tricuspid valve is usually dysplastic and stenotic, intact interventricular septum, ventriculocoronary arterial communication or fistula may be seen, hypoplastic pulmonary artery with retrograde filling by the ductus arteriosus. No association with chromosomal anomalies. Prognosis mainly depends on size and function of right ventricle and tricuspid valve. It requires immediate postnatal management at tertiary cardiac care center due to the duct-dependent pulmonary circulation. So, like such cardiac anomaly cases, first trimester cardiac screening can suspect more than 90% major cardiac anomalies and can be evaluated early before 20 weeks. So in first trimester cardiac screening, we have to scan only 3 views with and without color Doppler. First we have to see the fetal abdominal situs, and then cardiac situs, cardiac axis, and the 2 inflows of the ventricles and outflow tracts with their confluence. So some learning points. The abnormal ductus venosus flow in first and second trimester may be due to congenital cardiac anomaly. Some may be associated with chromosomal anomalies. More than 90% major cardiac anomaly can be suspected at first trimester cardiac screening. In some congenital cardiac anomalies like duct-dependent systemic or pulmonary circulation, total anomalous pulmonary venous connection, detransposition of great arteries with intact ventricular septum, there is immediate need of postnatal management required at tertiary cardiac care center. Thank you friends, and eager to see in the next case of the week. Bye.